Thank you for kind introduction, and thank you organization for inviting me in the seminar of the Shaping the New Multiple Myeloma Landscape ASH 2022 to present my cases from Tamam Hospital from clinical trial to clinic practice. So good evening, ladies and gentlemen. In next 15 minutes, to present my cases, I will take you some challenges and solution in 2023 and how resources can be used to solve these challenges. So first eye opener is which guideline we use to treat hematology and how do you choose therapies for multiple myeloma. We have these 4 top guidelines, and here in our hospital we use NCCN guideline, and my personal notes sometimes I use CCO expert online. So NCCN guideline, new version 2023, therapies for non-transplant candidate. There are options, preferred option, Dara-Lendex, RVD, and other regimens. And there are some other regimens which are useful in certain circumstances like VRD light in frail patient. So how do you choose? This is the challenge we will discuss. Similarly, primary therapies for transplant candidates, you have preferred regimen from RVD, KRD to DARA, RVD, and there are 10 of regimens which are useful in certain circumstances. Again, how do you choose? This is the challenge we will see. So multiple myeloma agents are present in multiple myeloma. So the newcomers are coming, but the important thing is how do we sequence and stratify therapies to ensure the best outcome for our patient. I do it like from A to D. First, you can say A means accurate diagnosis and staging. B, check you have to treat or not. C, choose the widely, and you have to stratify, hit the target if it is high risk multiple myeloma or low risk. And the important thing, even you see in NCCN, they have put not only ISS and cytogenetics, but also you have to check other factors as well, like renal failure and other like extramedullary disease. Then you stratify 5 different categories and then to treat accordingly. Second challenge is $1,000,000 question of 2023. Is patient with newly diagnosed myeloma, should we use best treatment first or you want to save for the later? Actually, multiple myeloma is a marathon, it's not a sprint. So you have to give benefit of early intervention. Here you can see if you treat smartly, the patient will enjoy good years of the PFS. Now, with this, I will show you my cases, 2 transplant eligible, 2 non-transplant eligible. One, this is 62-year female who was referred from some other hospital with acute renal failure, and she was diagnosed over there also amyloidosis, and bone marrow showed also clonal plasma cells. She has hypertension and diabetes. She had history of Beckett. Otherwise, she was fine. She has performance status 1 to 2. So we confirmed here the patient has 50% cellularity and 30% is clonal plasma cells. Cytogenetics is good, normal, but IS score, you can say high beta-2 microglobin and LDH and low albumin with a very high creatinine renal failure. So she has actually IgG kappa multiple myeloma stage 3B standard risk. So before beginning check indication, there is indication. Now, here you can say very high light chain 500 and creatinine was high in this graph. Now, again, back to NCCN, we have now choice RVD and DARA RVD. But as I mentioned, the patient is high risk because of renal failure. Here you can see, and very high light chain. So you have to, and because of renal failure, we choose in this patient as DARA CVD. So DARA CVD means daratumab, cyclophosphamide, Velcade, and dexamethasone. Our plan was to continue this 4 cycle, then patient will go for transplant. If she will not go for transplant, even you can say by NCCN guideline, patient should go for autologous transplants, first category 1. If not, will continue myeloma therapy or as a maintenance therapy. This was our plan. The patient has continued actually DARA CVD 8 cycles. Here you can say after 2 cycles a PR, and after 4 cycles she has complete response based on the IMWG response criteria. And so far she has completed 8 cycles of DARA CVD. And this is the whole journey of the patient. You can say light chain has become normalized, and CBC is normalized, LDH is normalized, all the factors is normalized. So she is enjoying now maintenance therapy. Now, case 2, 53-year-old male. He was actually seen in clinic with a weakness and tiredness. CBC was done, that revealed pancytopenia. We checked actually electrophoresis that revealed IgA, which was very high, about 60 grams per liter. And PET scan also revealed widespread bone involvement and extramedullary disease as well. MRI done that didn't show any cord compression. And bone marrow revealed plasma cells, clonal. Fish shows double hit 414 and 1Q amplification. He has history of hypertension in the past. So this is a bone marrow which revealed 60% of the expression of the cells, and these findings are compatible with a multiple myeloma. As you remember, as per NCCN, you have also to see other things as well. And as this patient, as I mentioned, have high LDH and plus, cytogenetics, which was about double hit here is mentioned. 2 clones were there. So the patient now has young male with a pancytopenia with heavy infiltration of very high IgA level and RISS stage 3. And he has double hit by fish and extramedullary disease. So by all these factors, you can say is very, very high risk patient. Naturally, we induce the patient with the quadruplet regimen, which is DARA RVD. Interestingly, after 1 cycle, his pancytopenia resolved, and he has completed 4 cycles of the DARA RVD with the Zomita, and he has gone for autologous transplant. So this is, you can say, successful point with the DARA RVD. After 4 cycles, he has complete response. And this is as per NCCN, either patient go auto or continuous. Patient agreed for good for auto, so he has gone. And this is the whole journey of the patient. Now the patient has gone for autologous transplant, and he will enjoy a very good PFS. Now, back to the patient who are not eligible for transplant, 78-year male, back pain with 3 weeks ago, and he has history of hypertension and diabetes. And we confirmed with the marrow 40% cellularity, 50% plasma cell, hyperdeployed cryotype, and ISS score, you can say A, B, C. A means albumin is low, B means beta-2 microglobin high, and LDH was also high. So the patient has high ISS score, stage 3, but standard risk. So before beginning, check the indication. Now, what is the best treatment for this patient who is not transplant eligible, about 80 years? So the evolution of treatment has gone MP and then Lendex, then RVD. Now we are in an era of DARA Lendex. So as per NCCN guideline, we have option category 1 is DARA Lendex for these patients, the preferred regimen, and you have other option you can choose is even VRD light as well. So somehow you put other things like an NCCN, International Myeloma Group. Number 1 is DARA RVD and ESMO, and plus, expert online, all the 5 expert online, they say DARA RVD, Lendex, DARA Lendex is the option. So in this patient, we choose DARA Lendex based on the MEA regimen. And this patient has after 2 cycle PR, then after 4 cycles complete remission. Now she has completed 8 cycle, and the patient has complete response, and he is on maintenance therapy. Now another patient, transplant ineligible 70-year lady who has history of ischemic heart disease, very poor performance status 2 to 3. She was found ISS stage 3, multiple myeloma. We were thinking either give light or mini RVD versus DARA RVD. Patient was very bad condition because of acute kidney injury, hypercalcemia, severe pain. So somehow we corrected all these things with the calcitonin, denosumab, and we started in this patient DARA Lendex with a low dose of lenalidomide. And you can see the important thing, the patient had destructive lesion in the distal right humerus, this one, which with the pathological fracture, and he has multiple lytic lesion. So, and you can see the beauty of the first cycle, and his calcium was very nicely corrected, and creatinine went also very nicely after first cycle. So this is the whole journey of the fourth cycle. It went down with the MIA-based DARA Lendex. And this is the whole journey of now 8 cycles is completed now on maintenance therapy, and the patient is in complete response as per IMW criteria. Now, if you go back, like I mentioned, 2017, we used to, this is multiple myeloma case, 78 year, and this is also standard risk. What we used to do, just I want to show you, we use SABOT and just PFS is only 6 months, then VRD was given, again, disease progress after 1.5 years, and finally we came DARA Lendex with chemotherapy, and now the patient is more than 2 years, he's enjoying PFS with the DARA Lendex best. So in the last 15 minutes, what I wanted to show you here, that multiple myeloma is not one disease. You have to stratify patient from patient 1 to patient 5, depending on not only our ISS, depending on other factors as well as NCCN also mentioned. The more important thing is, please remember, multiple myeloma is a marathon, it's not a sprint. So you have to treat early with the very efficacious drug decision to make the patient good PFS. So this is my take home for shaping the new multiple myeloma. I presented cases from clinical trial to clinic practice from Tamam Hospital. The challenge, you know, what was the challenge? Challenge was, how do you predict the best regimen in 2023? And we have seen we should use our best treatment first to get better PMS. And this is also based on the NCCN guideline in transplant eligible and transplant not eligible patient, even expert online, ESMO guideline and International Myeloma Group also endorsed this decision. So I am here. Thank you very much. We will discuss further questions.